Good afternoon, everyone, and welcome to the Cholangiocarcinoma Foundation's Thursday educational webinar. I'm Melinda Bikini, the Director of Advocacy with the Foundation. I'm also a long-term survivor of cholangiocarcinoma, and we're happy that you're here this week. And we're happy that we have Dr. Ian Kleckner, who is the Director of the Cancer Control Mind and Body Lab and Associate Professor at the University of Maryland, Baltimore. He studies how cancer chemotherapy causes side effects such as neuropathy and distress, and how to treat these symptoms using exercise and healthy eating. We invite everyone to put their questions in the Q&A in the chat. And after Dr. Kleckner's presentation, we will get to those questions and answer them the best that we can. And if I could just ask everyone to maybe keep your questions general and not too specific to your individual case, that would be great, as it's hard to comment on individual cases, but we can definitely answer general questions. But feel free to throw your question in the chat and we can decide that when it gets there. And I will turn it over to you, Dr. Kleckner. Thank you for being here.
Thank you very much, Melinda. Thank you, everyone, for attending. Thank you, Melinda, for the invitation. I'm very excited to be here and talk to you all about my work on exercise and the brain and chemotherapy-induced peripheral neuropathy. So please excuse my voice and my eyes. I'm sick, but it's not coronavirus. We can even get regular sick in a global pandemic, apparently. No matter how sick I am, though, I'm very excited to be talking about this. And I have my Twitter handle here. If you want to connect with me, I would love to connect with you on Twitter. I post typically a few times a week on exclusively on cancer research topics. You can also visit my website to get free copies of my papers. Don't tell the publishers. And you can also email me at my email address at the bottom. So I lead the Cancer Control Mind and Body Lab. The goal of my lab and all of our work is to understand how the body and brain produce subjective feelings and to translate that knowledge into treatments that help patients with cancer feel better. This is my chosen career path. This is really what I've been dedicating my career to. And I'm very excited to be able to share some of this work and our thinking with you all. I have no disclosures to share. So chemotherapy-induced peripheral neuropathy is a very common severe dose-limiting toxicity with few treatments. You might be aware of this, and I'll be calling it CIPN. It affects the hands and feet with numbness, tingling, pain, sometimes shooting or burning pain, sharp shooting pain, sometimes sensitivity to cold that can cause problems with balance, buttoning clothes, texting on a phone, writing with a pen, things like that, increases risks of falls. It is caused by so-called neurotoxic chemotherapy drugs, such as taxanes, platinums, vinca alkaloids, thalidomide, bortezomib, and for cholangiocarcinoma, the relevant drug would be oxaliplatin, which is used in many common regimens for cholangiocarcinoma and a lot of other cancers. That's what's shown on this slide. Most of the most common types of cancer in the US shown here are treated with neurotoxic drugs that I mentioned, including cholangiocarcinoma. CIPN is a dose escalating toxicity, which means that it gets worse over the duration of chemotherapy. So the more neurotoxic drug you get, the worse your CIPN is. And typically after chemo is done, studies have shown about 2 out of 3 patients have CIPN. And if you wait 6 months post-chemotherapy, about half of those people get better on their own, which leaves an entire third of patients with CIPN that is persistent. And some patients have CIPN for their entire lives. CIPN is also very expensive on the healthcare system, involving, on average, 12 more outpatient visits, 3 more hospital days, and $17,000 more in medical expenses for patients with CIPN compared to other cancer patients who don't have CIPN. Now, over the past decades, there have been a lot of research studies done on CIPN, and in fact, over 100 clinical trials testing different drugs or interventions to either prevent or treat CIPN. And you might say, wow, that's so much research. We know so much about CIPN. We probably have a lot to offer to patients. But I'm sorry, the answer is no. There's only one drug, duloxetine, aka Cymbalta, which can partially treat CIPN pain and some numbness tingling. But this drug is not very well widely used because it can be expensive, not covered by insurance because it's off-label use, and it has some gastrointestinal side effects. And a lot of patients feel that they don't want to take a drug to treat the side effects of another drug. So I don't blame them. All told, chemo-induced peripheral neuropathy is a dose-limiting toxicity, which means medical oncologists might basically reduce the dose, stop chemo, or switch to an alternate regimen because of CIPN, especially in palliative chemotherapy, where the duration of chemotherapy goes on and on and on until some toxicity limit might be reached. So why has there been so much research done on CIPN, yet so little that we can offer to patients that is proven to help them? Well, that's a big question that a lot of people wonder. And the National Cancer Institute had a meeting in 2017 of CIPN experts to try to figure that out. I think one of the main reasons is because we don't know enough about CIPN, so that these interventions that we're testing are not as well informed as they could be. It's like trying to navigate a room in the dark, in the pitch black. You have no idea where you're going. How could you possibly know where the furniture is or what is in the room to make use of it? So we need more research on CIPN from many levels to inform future interventions that are ultimately going to help patients. So this NCI meeting, National Cancer Institute meeting, which of course, if this is an international group, you hopefully know the National Cancer Institute is the biggest cancer research foundation in the US, part of the National Institutes of Health, paid for by taxpayers. Some of the key barriers were identified from this meeting was, number one, inadequate understanding of mechanisms of CIPN and its symptoms, like I mentioned. Lack of consensus on a consistent way to assess CIPN. If we're not measuring it in the same way, it's hard to know how to compare across these different studies. Poor understanding of CIPN's natural history, individual differences, phenotypes, intolerance to the symptoms of CIPN in terms of interference with their daily lives, and response to potential treatments of CIPN. CIPN clinicians who assess and treat CIPN will tell you that if you have seen one patient with CIPN, you've seen one patient with CIPN. It's quite different across different people, and that makes it very hard to study. There's also insufficient collaboration between preclinical and clinical researchers. So those who are studying CIPN in humans, such as myself, and those who are studying CIPN in rodents and other animal models. Now I'm going to go into exercise for the treatment and prevention of CIPN. I will tell you that exercise is one of the few promising and safe interventions that we can offer to people. It's been tested in a variety of studies, but it's not proven beneficial. And we don't know the limits of that potential benefit. So I'm going to tell you a bit about past, present, and future, and I will give you some very specific action items if you want to adopt an exercise intervention in your own life. So hopefully this will be very practical for you. So the first thing is, what is exercise? Of course, we think we know what exercise is in everyday life, right? You go to the gym, you pick up some weights, you get on a treadmill, you ride your bike, that's exercise, right? But in science, we have to define specifically what exercise is, and it differs from physical activity. So physical activity is when you're just going for a walk, you're moving your body, you expend some energy, but you don't necessarily have a goal. But exercise is a subset of physical activity that is planned, structured, and repetitive. And the goal of exercise is to improve or maintain physical fitness. There's also related concepts such as physical therapy, occupational therapy, and other types of rehabilitation. Exercise dose is an important concept. Just like a drug has a dose of milligrams or per body surface area or something like that, milligrams per meter squared, or you take ibuprofen and you have 100 or 200 milligrams of a drug. Exercise also has a dose. In exercise science, the dose is based on 4 things, sometimes called FIT, F-I-T-T. So that's really cute, isn't it? It's like fit, like, wow, you're getting fit. Whoever came up with that deserves some kind of an award. So this is frequency, how often you exercise, like 3 times per week. Intensity, which is like based on a maximum heart rate or perceived exertion. type, which is based on the broad class of movements such as aerobic or resistance or balance or some multimodal, and then time or duration, like how long each exercise sessions last in minutes. And then, of course, there's also how long you're doing the exercise over the course of weeks, and also whether it's supervised or unsupervised. The American College of Sports Medicine is a gigantic a group of exercise experts in around the world who come together each year and have an annual meeting. And a lot of these people, as well at ACSM, also offers credentialing to become a personal trainer or a clinical exercise physiologist. It's a really great organization. And they came together and with exercise oncologists to review the research on potential benefits of exercise for patients with cancer for a variety of symptoms. Now, there is evidence that exercise can help reduce the risk of cancer occurrence in terms of bladder, breast, colon, endometrial, esophageal, kidney, and stomach cancers, as well as exercise can help with the survival of other cancers such as breast, colon, and prostate. Now, there might be other benefits to other cancers as well, but they haven't been rigorously demonstrated by research, maybe because that research just hasn't been done. Also, when we're talking about cancer-related cancer and treatment toxicities, like for supportive care, which is my chosen focus in my work, we have things like cancer-related fatigue, quality of life, physical functioning, anxiety, depression, and lymphedema. There is strong evidence that exercise of this dose can be beneficial. So if you are a patient experiencing cancer-related fatigue and you are not currently exercising, you might want to think about doing some aerobic resistance or combination therapy, exercise therapy, because it's been proven to reduce that fatigue on average across many patients, hundreds and thousands of patients. So there's also moderate evidence for other outcomes like bone health and sleep. Now, CIPN is not on this list because it's not enough research has been done yet. So there's no strong evidence, there's no moderate evidence, there's inconclusive evidence at this point for chemo-induced neuropathy. However, research on exercise and CIPN is growing at an exponential rate. We look for PubMed, of course, you probably know PubMed as a gigantic database of peer-reviewed published scientific research. And if you search for chemotherapy neuropathy, you see quite a lot of pubs. This is a total pubs. Actually, no, this is wrong. It's actually publications per year. So you're coming on 2020, you have over 1,400 new pubs every year on CIPN chemotherapy neuropathy. If you look at just throwing in the search term exercise in there, you have about 35 pubs, new publications every single year on exercise chemotherapy neuropathy. It's also growing exponential. And so we're going to see more and more information coming out. These are some of the papers that I've worked on recently related to chemo-induced peripheral neuropathy and exercise. You can access these articles all for free on my website. If you can't get them, just email me, I'll send them to you. And the types of things that people are doing is a lot of review papers where we're reviewing what is the evidence available, because people are so eager to see what can we use to help people with cancer feel better. There are also many other reviews that exist. That's what accounts for a lot of these publications. And some of the publications are new studies with new data that are being reported for the first time. Now, when you look at what those papers are, what we know so far, I did a literature review about 1 year ago and found 23 human clinical trials and 2 rodent experiments with exercise and CIPN. And 10 of those studies, so basically they're aerobic resistance or balance sensory motor training. 10 of those studies are randomized controlled trials, which is the gold standard in clinical research, where you compare 2 different groups, interventions like exercise and a non-exercise control condition, and you randomly assign people to those 2 conditions so that you can make a causal inference that the exercise compared to the control had a causal effect on the outcome, like neuropathy. Most of these studies found exercise to be beneficial. Some studies found no effects of exercise, and no studies found exercise to be harmful. Now, you might know also in randomized controlled trials in clinical research, there are different phases. There's phase 1, which is very preliminary and safety, related to safety and feasibility. Phase 2, which is related to preliminary efficacy, like does this intervention, now that we know that it's safe and feasible, have any potential effect upon the outcome? Might exercise have any potential benefit? And then phase 3 is a definitive, where you're like, all right, I'm going to see if exercise has this beneficial effect. I'm putting all my chips on the table. It's like you're going to roulette or something. I'm putting it all on black. You're really putting your money where your mouth is. You say, is this actually going to be beneficial? And you get a definitive answer, yes, no. Well, there are none of those phase 3 randomized controlled trials published or pre-registered, which means that there are none that are even planned at the moment. And even if there was planned right now, it's probably going to be another 5 years before that study's done and published. But I will tell you about a couple projects that I worked on and published, and you can read about these. And this is some stuff that I've worked on with my mentor, one of my colleagues and mentors at University of Rochester at my former institution, Dr. Karen Muschin. Now, this study is very large, 355 patients. However, it is exploratory, which means that Dr. Muschin designed and ran this study looking at effects of exercise on fatigue, but she also happened to measure chemo-induced neuropathy. And that was very fortunate for me because that's what I was interested in. So I was able to look at her data and see if exercise had an effect on chemo-induced neuropathy. And we did find a beneficial effect, but it doesn't prove that it's beneficial because this is exploratory. This isn't a phase 3 study. This is more like an exploratory finding that we would have to go back and follow up with later. This is a simple pre-post, two time point pre-post, 2-arm randomized design where patients reported the severity of any numbness, tingling, and hot coldness in hands, feet on a 0 to 10 scale before and after 6 weeks of either exercise plus chemo or chemo alone during neurotoxic chemo, mostly women with breast cancer. All these patients were sedentary beforehand. The exercise intervention was at home, low to moderate intensity walking and resistance training. So they got a pedometer and had a daily steps goal. And they got these 3 colored stretchy bands and about 16 exercises to do each day. There was also a weekly progression in the number of steps and the intensity and the volume of the resistance exercises done. And what we found was that the exercise did help. So in gray, you see the control patients randomized to control. The severity of their hot coldness in hands, feet increased, okay, after those 6 weeks of neurotoxic chemo, whereas in the exercisers, it increased but by a smaller amount. So did exercise help? Yes, it looks like it did, but it didn't make the neuropathy go away entirely. It just kind of attenuated it. And when we look at for whom did this benefit the most, we see that older patients benefited the most from this. Okay, so the younger patients under 52 years here didn't have as much of a benefit as the older patients. And this is consistent with the idea of exercise dose. If someone is not doing enough exercise, it won't have the right benefit for them. If they're doing too much also, it won't have the right benefit. So you have to do the right dose of exercise for it to help you. And it's probably the case that these older patients in the sample were less physically fit. And this kind of low to moderate intensity training was just what they needed to get help. So it doesn't have to be a lot of exercise to help you. If you're not doing a lot, then doing a little bit more, it can be enough. If you're already exercising a lot, then you might need more exercise to get an increased benefit, or you might already be maximizing the benefits. You already might have those benefits. So those are some of the things in the past. Now I'll talk about research in the present. I'm doing a follow-up study. I told you that was a exploratory study, not designed to measure CIPN. Well, now we're doing a study and accruals are ongoing in Baltimore, Maryland. If you're in the Baltimore area, you might be eligible for one of my studies. So also I have a nationwide study. You might be eligible for that depending on where you live. So in these follow-up studies, they are designed to measure CIPN. We have a full CIPN questionnaire. We have brain MRI scans to look at the role of the brain in CIPN and some other measures of physical function and CIPN signs. And right now we're still, this study is 19 patients. This one is closed to accruals. It was a feasibility study, and we did find beneficial effects of exercise on CIPN, which was very encouraging. So this was a small study, but it was designed for CIPN. And so I hope I give you the sense that sometimes research can be a very big sample size. Don't get fooled. It might not be very rigorously designed, or it might be very exploratory. It's all useful information, but you don't want to necessarily be fooled by a large sample size. It doesn't mean that it's necessarily proven. And now this study was very rigorously designed, but the sample size is small. In the studies that I have ongoing now, I have kind of the best of both, where the sample sizes are a bit bigger and the studies are designed very rigorously, but it takes a while to get to that point where you can do those kinds of studies. Also, what we're looking at in our studies now and in exercise CIPN research more globally is how might exercise help? We know that exercise has beneficial effects on the nervous system, the peripheral nerves in the hands and feet in terms of reducing inflammation and other factors in the spinal cord, in the brain, and psychosocial factors like improving people's mood, anxiety, depression, helping people believe in themselves, increasing self-efficacy, and that they can do this. They believe that they can positively affect their body through exercise. All of those are very valuable and possible mechanisms that exercise might have a benefit upon CIPN. In our work, one of the things that we're doing that not a lot of other people are doing is looking at the role of the brain in CIPN. Now, historically, if you're paying attention, you'll know that the P in CIPN stands for peripheral, which means the peripheral nerves in the hands and feet. And that's where most of the research on CIPN has been conducted, looking at the nerves in the hands and the feet. But I told you in the beginning that there has been so much research done, yet so little to offer to patients. And I think one of the reasons is because we're neglecting another big player in the cause of our mental states and symptoms, which is the brain. And I'm not saying that chemotherapy goes into the brain. I'm saying that the brain has a reaction, a compensation to the damage done of chemotherapy to the periphery and to the spinal cord. And this is a new perspective that we've published on. Medical student Miriam Amrin, we published this just last year, reviewing this novel perspective that there are changes in the brain that might contribute to CIPN. And if we address those changes in the brain, maybe with targeted therapies like exercise that targets the brain, or meditation, or some type of brain stimulation, or just something that we haven't thought of yet, we might be able to help people better than what we've been doing now. So now some clinical implications for what we've talked about so far. I'm working with a great group of individuals, Stephanie Stoller and Scott Capozza, who are two physical therapists who treat patients with CIPN pretty much every day. And they work together with Dr. Miriam Lusberg at the Yale Cancer Center. And the four of us are writing a paper together about what physical therapists can say about the treatment of CIPN. And I'm going to get into some practical things here. I've told you a lot that it's not proven that exercise can treat or prevent CIPN, but that doesn't mean it's not worth trying, right? Because we know that exercise is something that can be beneficial for those other toxicities like fatigue and health-related quality of life. And we know that when it's done safely, done properly under the supervision or with the training of a certified expert, it can be very safe, and it's a great thing to include in your life. So that said, how can we make some actionable items for patients? So these physical therapists and others around the world are doing exercise interventions with patients, just like when doctors maybe give a drug that seems promising and will monitor the response in their patient. We can use exercise and physical therapy techniques to help patients prevent or treat their CIPN, even if it's not been proven beneficial across across hundreds of people in these phase 3 studies. Here's what we came up with. If you want to take a screenshot of this or whatever, you're welcome to do that, and bring this to a physical therapist or an exercise personal trainer, a certified trainer, or something like that. If you miss this, email me, and I'll send it to you. This chart, this table shows a different, each row is a different modality of exercise: sensory motor, resistance, endurance, and whole body vibration training. You don't have to do it all, but this, if you do have access to this type of equipment, and someone with the expertise to deliver it and train you and to do it safely. And once you know how to do it, a lot of these you can do on your own. And if you don't have access to a trainer, you can certainly go for a walk or a run if that feels comfortable and safe for you. But, with neuropathy, people sometimes have problems with balance, increased risk of falls. So you might want to do like a stationary bike instead of a run because it's a lower risk of fall. Okay, we have frequency, duration, intensity, and some example exercises. If you bring this to a exercise trainer, they'll say, wow, thanks, this is a great starting point for us. They'll help work with you and figure out what's a good amount of exercise to start low and grow slow. And you might experience some benefits for neuropathy, and you will probably experience some benefits for some of those other things like fatigue. Now we're going to move into the final section, which is the future, seeing where is exercise CIPN research and clinical practice going. Well, number one, we need better designed studies of exercise for CIPN. I recently co-authored a paper with an international group of CIPN experts looking at kind of what do we measure in CIPN research and exercise. And we need to measure the same things to some extent across these studies. Otherwise, it's going to be impossible for us to compare because we're going to have a lot of studies, but we eventually want to formulate some guidelines that are proven beneficial. And so we need to have basically assessments of CIPN symptoms, physical function, and other related outcomes. so that the quality of these studies are improving and the consistency across the studies done by different research groups around the world are all increasing. So hopefully that gives you some sort of sense of confidence in that we researchers are really working together in international groups to figure out how we can collectively all do our own research that is synergistic and works together to help patients feel better. Also, we're looking at studies of mechanisms. A mechanism is just an explanation of how something works. Some mechanisms can be very simple, like how does a key unlock a door? And the mechanism is that there are teeth on a key and that the teeth go into the barrel of the lock and it activates the right pins and will unlock the door. If you didn't know the mechanism, you couldn't realize that you could copy the key or something like that, or you could pick a lock. So if we're trying to understand how might exercise treat CIPN, we want to understand the mechanism of how it works so that we can improve it. Maybe we can make it better. Maybe we can use it to prevent CIPN in people who don't even have it yet. Okay, so in mechanisms, there are two main things. One is called a mediator. This is along the causal pathway. Mediators are things, in the left here you have exercise, on the right you have CIPN. Exercise might have a direct effect on CIPN and also could go through these mediators. A mediator is something that has to change along the way. It's saying that exercise has to change these mediators in order for it to change CIPN. The key has to go and activate the right pins in the barrel in order for it to unlock the door. The mediators for exercise and CIPN that we think are interleukin-10, that's cytokines, inflammation. You probably heard of inflammation. Also self-efficacy and social support. Those are mediators that we think, if we understand this enough, we could make exercise work really well to target those mechanisms, just like we can make a copy of a key really perfectly match and unlock a door. Moderators are things that amplify the effects of the intervention of exercise on the outcome. Moderators are things like age or body mass index or physical fitness. If you're really physically fit you're going to need more exercise perhaps to have a benefit. If you have a higher body mass index, or if you're older, like in the example I showed, you might need less exercise to have a benefit. And those are some things of moderators. There might be other moderators that we don't know about, but a moderator is nice because it's something that we can use to identify who will respond best to exercise. This is something that maybe a clinician can ask you about or know in a patient, or measure with a blood test or a questionnaire, and say, wow, it looks like you could really benefit from exercise based on what we know about exercise research. A mediator is something that can be leveraged to optimize or tailor the exercise. Like I said, if inflammation is involved, you could say, let me make an exercise that is so anti-inflammatory that it will have an even bigger effect. Okay. I have to point out that this is a paper first authored by a young woman, Caitlin Chung, who just graduated high school. I couldn't believe it. She's in high school and she wrote this paper under my supervision. She is brilliant, and she's going to go on to do some really amazing things. She's going to undergrad at Cornell. Here are some of the mechanisms: inflammation, brain-derived neurotrophic factor, brain structure and function, and mitochondria. So we wrote this paper, that Caitlin and I and others wrote this paper to show other researchers, hey, here are some things that you should add to your study. Please measure these things, because if we can fill this in, we can not only know whether exercise is helpful, but we can have more information about how to optimize it for the future. And then I'm going to kind of wrap up pretty soon. Here's some ongoing research. A lot of clinical trials are pre-registered on clinicaltrials.gov and other places to say, hey, I'm going to be running this study, or I'm currently running this study. You can either join my study, or you'll know, if I'm going to make a research study, I go to clinicaltrials.gov and I make sure that no one else is doing that, because if they are, boy, that would be a waste of resources. There are 19 studies currently about 20 or 24 studies pre-registered that are planned or ongoing exercise for CIPN. In the next 5 or so years, we will be seeing these studies complete, published, and with more information. There are still no phase 3 studies currently pre-registered, but hopefully in the next 5 years, there will be some. And hopefully in the next 10 years, we will have the results of those phase 3 studies. Some of my future work, I have 3 studies ongoing right now. These first 2 are being conducted in Baltimore, Maryland. One is for women with breast cancer. One is for people with gastrointestinal cancer, which would include cholangiocarcinoma. And one is a nationwide study. They all use exercise in some form for either the prevention or treatment of CIPN. This study is run by through an NCI's NCORE network, which is a network of community oncology practices around the world. We have sites that are either activated or going to be activated right now in Missouri, in Illinois, Florida, North Carolina, Ohio, and some other places are interested. If you are nearby one of these sites, you can join my study if you have CIPN and if you completed and meet the other eligibility criteria. Finally, the goals for future work, definitely more definitive knowledge of how exercise affects CIPN and those mechanisms to help optimize exercise. Number 2, trying to do these studies that give us a deeper understanding of mediators and moderators, which help us optimize exercise. We are going to be seeing studies with different chemotypes, different exercise programs, acute exercise, which means just one exercise session versus like weeks and weeks of exercise. We're going to see more and more larger trials coming out, more real world trials that occur in the community, not just at large academic medical centers. We're going to see studies coming out that address health disparities like ethnicity, income, rurality, all for the use of exercise in CIPN. And we're going to have more and more that we can offer to patients so that when a patient gets their cancer treatment, we'll know what to do to help prevent the CIPN. The clinical implications are results of future phase 3 trials. I'm thinking that in the farther future, we will probably have tailored exercise for every patient who has a diagnosis of cancer and is safe and desires to exercise. Then they will have a workflow that leverages knowledge of how to optimize exercise for that person, personalized exercise based on that person, individual, their age, their BMI, their exercise experience, maybe the symptoms or the cancer type that they have, the treatment they're going through, what types of exercise they like. There are going to be more studies suggesting things like Zumba or dance or other like, say, non-traditional exercise modalities can be offered to patients in proper dosing. And with that, I just want to say thank you to the people who contributed to the work. Here are the people in the Cancer Control Mind and Body Lab, especially Amelia Wagon-Connect, who hopefully some of you recognize, who is an active contributor in the Cholangiocarcinoma Foundation and who made this connection for me. She's a coordinator in my lab, and she's really outstanding, hardworking, intelligent individual, and contributed a lot to this. And she's helping to run those other studies, as well as my mentors at my prior institution and my children and my wife. And thinking about when I do my research, I really want to make the world that they grow up in and that everyone grows up into to be a better place through research. So thank you very much for your attention. Happy to take any questions.
That was great, Dr. Kleckner. Thank you so much. And your children are beautiful.
Thank you. Yeah.
All right, we do have a few questions that have come in. Were the exercise trials based on the age of patient? And I think you did say that, but maybe elaborate a little bit more on that.
Okay. Yeah. So thank you for the question, Beth. So were the exercise trials based on the age? So for these studies, the short answer is no. It was 18 plus. They have to be at least 18 years of age, and they were eligible to participate. The exercise intervention was not based on their age per se. It was based on their baseline physical fitness. So what we did in these studies was we'd give people, and a lot of our studies would give people a pedometer, like a Fitbit, and have them wear this, and we measure their ongoing physical activity. And then we base the exercise prescription on their baseline physical activity. If someone comes into the study and they're incredibly active already, but not yet exercising, their exercise prescription will start at a higher level and build from there. If someone is very sedentary and not yet exercising, and they're coming in at a lower level, we start their prescription lower and then build from there.
Okay. And then Deborah wants to know, does Abraxane cause CIPN like taxane in addition to platinum-based chemo in cholangiocarcinoma patients?
Yes. So taxane-based and platinum-based drugs both can cause neuropathy. For taxane, docetaxel, paclitaxel, Abraxane, yes. Also in platinum, it's particularly oxaliplatin. They both cause neuropathy, but through different mechanisms. The taxane drugs are microtubule inhibitors, and the platinum-based drugs are DNA intercalators. They both interfere with cell replication. The platinum agents, though, do have the noteworthy features of cold sensitivity. And patients who've gotten like oxaliplatin might have experienced this right after their infusion. You drink a cold water or you go out into cold air and you can feel it in your throat, sensitivity. That's a nerve, that's a neural effect of neuropathy that also can affect the hands and feet. The taxane drugs don't have that feature, but so that's why we do studies in both. Yeah. So we can see maybe exercise can help one but not the other, or one more than the other, or if they help both, we want to know that and need to study it separately.
Yeah, and all of our patients, the standard of care is gemcitabine and cisplatin. So we've all had the platinum-based chemo. Okay, oncologists don't talk to patients about exercise, etc., and only talk about the symptoms of neuropathy. Maybe how do we start that conversation?
Yeah, that's very unfortunate. I think, you know, people. I have a friend and colleague, Dr. Richard Dunn, who's a GI medical oncologist, and he has on his Twitter, you could follow him. He's really wonderful. He says, I don't know who needs to hear this, but you know, the cancer care for a medical oncologist doesn't stop after chemo's done, and you have to talk about these supportive care things. Yeah, you know, I would say, I don't want to give medical advice, but the research suggests that if a patient who doesn't have advice from an oncologist about exercise, that patient might benefit from going to a physical therapist or an exercise trainer on their own, with maybe like the table that I had or something else, or the ACSM guidelines to get started, because the oncologist, in the best case, can refer to exercise or write on a piece of paper, please exercise or something. But they ultimately won't be there to help you dose it because they don't have the time and expertise. But please don't let that stop you from going on your own to try to do some exercise or with a certified professional.
Okay. Is there a connection between edema and peripheral neuropathy?
Yeah, I mean, they have common symptoms. So, I mean, definitely this is widely explored in breast cancer. When a lymph node is removed and a patient gets lymphedema, there can be common symptoms, including nerve damage and things like that. So it's not chemo-induced peripheral neuropathy, but it could be a type of nerve damage caused by a common cause of both edema and the nerve damage. Now, I don't know a lot about exercise for that type of nerve damage, but it stands to reason that exercise would be beneficial because of the common mechanisms of inflammation, being a contributor to nerve sensitivity, and exercise having an anti-inflammatory effect.
Okay. Beverly wants to know if we can receive copies of the slides to share with the oncologist. Dr. Kleckner, whatever you can share with us, you can send to us. And if you guys just email me, I'll make sure you get them.
Would be happy to do that. None of this stuff is unpublished, so but I'm guessing that the chart is probably, those two charts are probably what you're interested in most.
That would be helpful. And this is being recorded and it will be on our YouTube channel for viewing later if you wanted. Okay, so Marilyn wants to know about electrical stimulation of the feet and hands. Is that helpful at all? And what about massage and warm hot foot baths?
Yeah, great question. So electrical stimulation of the feet and hands is another intervention that seems promising, yet is not proven for the treatment or prevention of CIPN. I have a colleague, Dr. Jennifer Gawanter, who has just finished a phase 2 trial of transcutaneous electrical nerve stimulation for the treatment of chemo-induced neuropathy. I'm excited to see what she finds. It's something that, yeah, definitely you need obviously a trained professional to help deliver, to dose that for you. And it could be beneficial. There's also something called scrambler therapy that is kind of a more rigorous, electrical stimulation, but you have to go into the clinic to do it. The TENS, like transcutaneous electrical nerve stimulation, TENS, TENS. You could get a device and then wear that and do it at home. So basically promising, not proven. Definitely ask a neurologist or someone about, can you get started with TENS, and they might be able to supervise you and you can see if it helps. Okay, what about massage and warm hot foot baths? It says it's supposed to be massage. Now this is kind of interesting because during chemotherapy, one of the other promising interventions is ice on the hands and feet during chemotherapy infusions. The idea is that it restricts blood flow, or even compression therapy, cryocompression therapy, or compression therapy, or cryotherapy. The idea is that it restricts blood flow and therefore the circulating levels of chemotherapy drugs, when they're highest during the infusion, don't make it out to the fingers and toes, hands and feet, and therefore it kind of spares those areas from the neurotoxic effects. But then also you have other things like massage, which like definitely does increase blood flow. And I've seen that being done during infusions. So I think if you have a condition, if there's a person who already has neuropathy, it would seem like, and it's chronic, like probably do whatever feels good. If it is during an infusion, I probably would stick to the things that have been more like suggested to be helpful, like ice on the hands and feet. And again, it could be extremely painful if you do ice on the hands and feet. The studies have shown that you tend to need a degree of coldness that is very uncomfortable. So that nut has not been cracked yet.
Yeah. So does CIPN plateau or get progressively worse? And I'm a 13-year survivor, and as we're sitting here talking about it, I still have neuropathy. So I can tell you that mine hasn't gotten worse, but it's stayed the same.
Yeah. Someone asked about cisplatin. Yeah, cisplatin is highly neurotoxic. The platinum drugs are cisplatin, oxaliplatin, and carboplatin. Oxaliplatin is the most neurotoxic. Cisplatin is also quite neurotoxic. A carboplatin is not very neurotoxic, actually.
So what about the plateau and progressively worse with chemo?
Yeah, so the natural history of CIPN, there's basically, it is a dose escalating toxicity where it gets worse typically during the infusions of chemotherapy. In platinum-based CIPN, there's a phenomenon called coasting, where it looks like the symptoms have plateaued and then chemo is stopped and then they get worse. That doesn't really happen in taxane chemo as far as I know. And then if you look back at my first slide, or one of the early slides here, this one, you could see that for a lot of people, they just get better on their own. So about half the people get better in 6 months. The people who don't get better, I've heard that the half-life is about 7 years, which is extremely long. So it tends to plateau. It might get a little bit better once it gets, yeah, basically. So I guess, does that answer your question? Is that enough info?
Yeah.
It could be complicated. It could get worse. Then you stop chemo. Then it might get even more worse. And then it probably gets better. And then probably at some point, the rate at which it gets better will be incredibly slow. Yeah.
Yeah, for sure. 2 questions on what about the benefit of acupuncture?
Yeah, acupuncture is also one of the interventions that is suggested beneficial, but not proven beneficial. From what I have seen, and I don't know this literature super well. A lot of the studies have not used sham acupuncture, so the designs of the studies are not as rigorous as some would like. There is a sham acupuncture where you have not doing on the correct points or whatever, but you still go through the process. I don't think there are any, I mean, it's definitely not proven beneficial. Acupuncture is probably something that you could throw into the mix when done. It could be safe and beneficial for other things besides CIPN when done by a trained professional. So if you have the opportunity and the means to access that, it seems like that would be a good thing to try to do.
Okay, and then we had a question come in from Facebook. Dawn says, talking about the brain, biofeedback wasn't mentioned. Is this an option along with exercise, meditation, etc.?
Yes, thank you for the question, Dawn. So yeah, the short answer is like maybe it could be beneficial. I think hopefully you will find a theme in what I'm saying, that a lot of things for CIPN are not proven beneficial, but they could be promising, and if done properly with the help of a trained expert, they're also safe. So I would not shy away from pursuing any intervention that can be done safely and that is promising. Also, these clinical trials, if you have a study in 500 people and half of them have a benefit and half of them have a small benefit and half of them have no benefit or something like that, you might not see any benefit on average. Or if half of them get better and half of them get worse, on average, there's no benefit. But there are individual differences, those moderators that I talked about, like age or BMI or anything that might make it beneficial for you. So it's good to try. The role of the brain in CIPN is not very well known, and by extension, interventions that target the brain are even less well understood. There is a study looking at electroencephalography, EEG biofeedback for CIPN. It's published by a woman named Dr. Prinsloo, Prinsloo, and that exists. I can't remember the study design. I think that the case was that it is not a sham biofeedback condition where it looks like biofeedback, but it's not really biofeedback. It's a great study. You can check it out. It doesn't prove that biofeedback is helpful, but it does help us learn about the brain, and it is a great first study. Is exactly where the research should be going. I haven't seen more follow-up from that.
Okay. And maybe lastly, Dr. Klickner, if you want to talk to us just a little bit more about the current clinical trials that you're running, like what they consist of. Would it require coming in to the site, weekly, daily, things like that?
Yeah, okay, sure. So these two studies, we have 3 studies right now. These 2 are in Baltimore, Maryland. The third one is a nationwide study. In these studies, all of our exercise interventions can be done at home. The exercise intervention can even be taught via Zoom video meeting. And that part is, it makes it quite doable, feasible, easy to disseminate. For the measures of the study, patients do have to come in. This study and these first two involve a 12-week exercise intervention with 3 visits to our lab, including things like a touching test, a walking test, a hand grip strength test. All these studies also involve brain MRI scanning. So you'd have to visit an MRI scanning facility to get those scans done. This third study is a 6-week long exercise intervention for patients who already have existing CIPN. And there would have to be 1 visit in the beginning and 1 visit at the end of the study. So I wish I could say that like my studies are very straightforward and low burden on the patients, but really they're not that. I wish I could say that, but the patients would have to come in a few times. And believe me, we really do everything in our power to make the study easy and fun and potentially beneficial to patients. Everyone on our study gets a free exercise intervention, a Fitbit, a charge 3 to keep. We pay them typically $100 to $200-ish to compensate them for their travel time and effort. And a lot of the people on our study like the time and attention that we provide with phone calls every 1 or 2 weeks and things like that. And for the patients who are attending, if you've participated in research, I want to thank you all. And if you're considering research, this is the way that we learn these things. We haven't figured out how to do a brain imaging, from home or something. I wish there was an easier way to do some of these things. But when you do participate, this is how we get this information to ultimately help patients feel better. And if you can't participate in a study, but you want to, don't feel guilty to, you can still benefit from the knowledge gained, or you can ask me questions or anything. I really hope you get the sense that in my lab, we all are so passionate about doing research that helps patients with cancer feel better. This is exactly what we want to do, and to share this information with people, for the benefit of all.
Yeah, well, it sounds like it's very patient-centric from what you described, and clinical trials in cholangiocarcinoma, we know how very important they are, and we have so many patients who participate. So I hope that many patients will be able to look into your clinical trials and have the opportunity to join. This was great information. I'm so grateful that you were here to share it with us. And I don't see any other questions, so I will end the webinar here, but I just want to thank you again, Dr. Klickner. We appreciate it so very much.
Yeah, thank you for the opportunity. This was a great conversation, and feel free to connect with me on Twitter or by email, or visit my website or anything, or contact Melinda and she can put you in touch with me. Thank you very much. Take care, everyone.
Happy to do it. Thank you. Have a great day.
Thanks. Bye.
Bye.